Well, good evening and welcome to Healthy Living for Weight Loss, Setting Yourself Up for Success, a virtual event with Dr. Shayani. Dr. Shayani completed medical school, residencies, and fellowship in minimally invasive surgery at George Washington University. He is board certified in general surgery by the American Board of Surgery. Dr. Shayani is the Bariatric Medical Director with AdventHealth Bolingbrook Hospital and has served in this role since 2009. Additionally, Dr. Shayani serves as the Vice Chairman of the medical staff. Previously, Dr. Shayani served as an Associate Professor of Surgery at Loyola University Medical Center and as the past President of the Illinois Association for Bariatric Surgeons. Dr. Shayani, the floor is all yours, and thank you for attending.
Thanks, Chair. I appreciate it. It's a great pleasure being with all of you this evening. If I had my druthers, I would say I would like to keep this informal and ask all of you to raise your hands and participate in asking questions throughout the presentation, but I have been advised against it. I've been told I need to do a quick presentation, and then we will go to questions and answers after that, and I'll be delighted to take all of your questions. And again, thank you for spending a portion of your evening with us tonight, and we hope to do these educational sessions a little more frequently. And so stay tuned with future dates and future topics for discussion. As you can see from this slide, to me, the glaring information is a exciting new collaboration and partnership with University of Chicago Medicine. This is something that has started as of January 1st, and we do advertise it exactly as we mean it, which is having the best of both worlds, the feel of a community hospital in your backyard, as well as the support of a major tertiary care center, a major university. And we are excited to bring that together as of January 1st. What I'm going to do tonight is pretend like I am sitting across from a patient in the office and discuss all of the options for weight loss with all of you. And I'm going to try to keep the presentation to 30 minutes or less so that we have a good bit of time afterwards to go over all of your questions. This is a little bit of background about me, and I think Cher already went over that, so we'll go to the first slide. In my world, we generally talk about, or patients ask me, what's the best intervention? What should I be looking for? And the answer is, it depends. It depends on what each person is hoping to get from that particular intervention, how much weight a person needs to lose, how much risk they are willing to take. And I don't want to make that sentence sound scary, but clearly, as you can see on the x-axis, the higher we go on the intensity of intervention, and let me go to the next slide, the larger the amount of expected weight loss results. So, for example, what most of us at one point or another in our lives have tried is diet and exercise, fairly low in intensity of intervention, but also fairly low in the amount of expected weight loss. Then from there, we might try something like meal replacement, and I'll go into details about each of these categories, a little bit more intense and a little higher weight loss results. And then the next one would be diet pills, something that everybody's talking about these days. There was a time when we talked about diet pills, we had one or two options. Today, we have lots of FDA-approved appropriate medications for weight loss, which deserve probably a whole lecture talking about them, but I have dedicated one slide on that subject, and we'll talk about that. And I'm sorry. And then we have low intensity endoscopic procedures that don't require surgery. Rather, we do it endoscopically by going through the mouth and getting into the stomach and doing something to the stomach. I'll talk about that a little more. From there, perhaps lap band surgery, which is the least invasive surgical procedure available to patients. Then gastric sleeve. You can see a little more intense, a little more expectation of weight loss. And next category is gastric bypass. an operation that at times has been referred to as gold standard. Today, uh, there's less than 20% of all operations are gastric bypass. Therefore, some people question how an operation can be gold standard if it's less than the majority of procedures being performed. We'll talk about that. And finally, the most aggressive of operations, duodenal switch. So I'll talk a little bit about each of these interventions, and then please keep your questions, write them down so that we can discuss all of those at the end. So we all talk about diet and exercise as the main lifestyle change that can help all of us lose weight. And clearly, diet and exercise do work, but they tend to work for people who have 10, maybe 15, possibly 20 pounds to lose. Why? Because the amount of um, the degree of negative caloric balance you can create by going on a diet and by exercising is small enough that you might see somewhere around half a pound to a pound weight loss in a week. And that level of weight loss tends to be a little too slow for somebody who has 100 pounds to lose. If you have 10 or 15 pounds to lose, half a pound to a pound a week is totally appropriate and acceptable. All of us have done that at one point or another, and there are various diets that we all hear about. There's a low carbohydrate diet that is popular. There is intermittent fasting that is popular. There's all sorts of ways to reduce the amount of calories so that ultimately we are in a negative caloric balance, less calories taken in compared to the amount of calories that we burn. And what I tell all of my patients is that there are three general rules that apply to anybody who wishes to lose weight, whether it's with a surgical procedure or without any surgical intervention. And those three rules um, are things that you should write down, paste it to the refrigerator, and pay attention to all the time. These apply to anyone who hopes to lose weight. They're not necessarily appropriate for our teenagers that are very fit and live a very active life, and they're trying to grow. I don't necessarily promote this to those people. But a person who's trying to lose weight, number one, they should do their best, to limit their eating to only when they are hungry. Anybody who tells you that you have to eat to lose weight is not doing any service to you. No, you don't have to eat to lose weight. It's okay to skip breakfast if you are not hungry. It's okay to skip lunch or dinner if you're not hungry. One thing you don't want to do is to deprive yourself. But if you're honestly not hungry, it's totally okay having a cup of coffee that might have 25 calories in the morning instead of having a full plate of breakfast, which might have 500 calories. So, rule number one, don't eat unless you're hungry. Rule number two, liquid calories are processed by our stomachs differently than solid food. So, it is really important to avoid high calorie liquid forms of either food or beverage. And by that, I mean, I'm not in favor of protein shakes unless that's all a person is doing. If a person is doing meal replacement and they're having a shake for breakfast, a shake for lunch, a shake for dinner, and the total calories are designed to be very limited, that might be acceptable. But in general, having your calories in liquid form is not the best way of losing weight because the liquids don't stay in the stomach long enough to provide a sensation of fullness. So I discourage my patients from having shakes or soups, or adults don't need juice or milk. And of course, we have to be very careful about sugary beverages and alcohol consumption. All of those fall in the category of liquid calories. And then um, let's have a moment talk about different types of molecules that are included in our food. Carbohydrates are the easiest processed molecules as a source of energy for our bodies. So our bodies love taking carbohydrates, breaking it down, and turning it into energy. As long as we introduce carbs to our body will preferentially use those molecules as a source of energy. What we want to do, those of us who are trying to lose weight, is to push our bodies into a fat burning mode. And the only time our bodies go into fat burning mode is when carbohydrates are not available. So, in fact, a carbohydrate depleted diet is the appropriate diet for people who are trying to lose weight. People who are blessed and who are at a healthy weight already, they need to be on a well balanced diet, a diet that has a little bit of carbs, a little bit of protein, a little bit of fat. But we're talking about patients who are desperately trying to lose weight. And one of the three major rules for dietary restrictions is avoiding carbohydrates as much as possible. I'm going to move on to the next slide. And as far as exercise is concerned, yes, I want everyone to consider exercising regularly. Why? Because I want them to have better cardiovascular conditioning. I want them to build some healthy muscles and, in general, enjoy the contour of their body as a result of exercising. And let's not forget that the release of endorphins as a result of exercise generally make us feel better about ourselves. People who have incorporated exercise as a daily activity will tell you right after exercise, they feel great about themselves. So, those are all the right reasons to exercise. Is it possible that everybody who exercises will see weight loss as a result of it? The answer is there have been many, many studies that have been done that show overall you can't necessarily expect weight loss from exercising. And there are two good reasons for that. Number one, when we exercise, we tend to get hungry afterwards. So it's enough to have one extra snack or meal after exercise to outdo all those benefits of burning the 300 or 500 calories that you burn by being on a treadmill or a stepmaster for an hour and a half. So essentially, if you treat yourself to a snack or an extra meal, now you no longer are seeing the benefits of having burned extra calories. There's a second problem. Many of us, after doing exercise, come back to changing our daily routine. Let me explain that a little differently. I generally come home from work, and when I come home, there is a list of things that I have to do to complete my activities that started earlier in the day. I have to um, help my family with chores around the house. All of those things result in burning calories. Now, if I go from work to exercise for an hour and come home exhausted, I am likely to sit down, have a meal, and then plop myself in front of Netflix and watch TV the rest of the night. Why? Because I feel like I've done enough. I just came from lifetime exercise. I uh, I had a vigorous exercise for an hour. Now I'm tired and I deserve to sit down and watch TV. So as a result of that, the remainder of the activities for my evening changed. If I hadn't done exercise, I would have come home and done some chores and gone to the basement and fixed some of the things that needed to be done. But because of the exercise, I didn't do that. So overall, my message to you is yes, exercise a is a great way for all of us to improve our health. But I can't promise you that by starting to exercise tomorrow, you're going to see significant weight loss associated with it. And I'm happy to answer questions at the end about this. Meal replacement, I think everyone on this call is familiar with items like OptiFast and HMR and many, many other products out there. I include Jenny Craig and Nutrisystem. Basically, any product that you purchase that becomes your main source of calories and essentially replaces what you would buy from a grocery store or what you would fix using the oven can be referred to as meal replacement. Meal replacement works, but it would only work if you stick with it for a long, long period of time, if not forever. So basically, if you're going to benefit from meal replacement, you have to commit yourself to purchasing prepared meals or shakes and protein bars instead of eating regular food. And one of the greatest advantages of trying meal replacement is to find out what the threshold for each of us is, below which we will start seeing regular weight loss. Let me explain that to you a little bit more. Most adult Americans are expected to eat about 2,000 calories a day and to burn around 2,000 calories a day so that their weight will stay around the same during their adult life. Well, unfortunately, as we get older, the amount of exercise or regular activities of daily living tend to slow down. And as a result, we may not really burn 2,000 calories. We may only burn 1,800 or 1,500 calories. Now, imagine that you're burning only 1,500 calories, and not only you're trying to not gain weight, but you're actually trying to lose some weight. So now you have to consume a lot less than those 1,500 calories to see actual weight loss results, which means for many of us, we may have to settle for something like 1,200 calories a day. And what meal replacement allows us to do is to play with that number and see at what level of caloric intake we see regular weight loss on a weekly basis. So I would, for example, say to myself, starting tomorrow, I am going to only eat what comes out of a box that has a label on it that tells me how much calories there is in it. And I'm going to add it up to about 1,500 calories and see if I ate 1,500 calories every day. At the end of the week, I would see weight loss. If I don't, I have no choice but to reduce that number because for my level of activity, 1,500 calories clearly isn't working. Then I have to go down to maybe 1,300 calories or 1,200 calories. So eventually, a threshold will become very obvious. And if that threshold is very, very, very low, like somebody would only lose weight if they're down to 900 or 800 calories a day, that would give you an idea of how seriously you might consider thinking about interventions like bariatric surgery or an endoscopic procedure that helps you reduce the calories to those numbers like 900 or 1,000 calories a day without the feeling of deprivation or feeling hungry all day long. So let's move on. I'm going to move to uh, diet pills as promised. This is something that everybody is talking about today. The list that you see before you is simply an alphabetized list. It's not based on popularity of the item. It's not based on what item became FDA approved first. It's simply the list of FDA approved medications that are available today. The last one, Mounjaro or tirzepatide, is a medication that is on the cusp of being approved by FDA. Those of you who have heard about Ozempic and Wegovy, similar medications, slightly different dosing, um, uh, would like to know that Mounjaro or tirzepatide is a cousin of these medications, which appears to offer even a higher level of weight loss. So in clinical trials, patients who have tried tirzepatide have lost about 25% more weight compared to semaglutide, which is Ozempic and Wegovy. And as you can see, the list includes medications that in the past have been super um, popular, as well as medications that are still Today, the most commonly prescribed medications remains phentermine. Phentermine is the most commonly prescribed medication, but there are many people who believe that in the near future we are going um, to be prescribing more of the semaglutides and tirzepatides because of their low um, degree of side effects. There are some side effects with all of the medications you see on this list. Side effects could include nausea, even some vomiting, some abdominal cramping, and you may wonder how do these medications work? The majority work by a combination of two things: some central nervous system activity, which helps with reduction in appetite and hunger, and also some changes in the stomach itself, such as prolonged gastric emptying. So when we eat a meal, the food tends to stay in the stomach longer, and as a result, give us a prolonged sensation of fullness. So the time period from one meal to the next, instead of being 2 to 3 hours, might become 4 to 5 hours or 5 to 6 hours. I personally believe there is nothing wrong with every healthy patient who can tolerate the potential side effects of diet pills to try to give them a try. I know a lot of people who come to my office express anxiety about what happens when I come off of the medication, or my doctor has told me that I can never come off of the medication. And the truth is, we did have some anxiety about long term use of phentermine. Phentermine is a drug that does have some cardiovascular effects, and we do worry about patients being on it long term. But the newer generation of medications, the diabetic medications, patients can stay on them long term. And for those of you who have anxiety about being on Ozempic for a prolonged period of time, I would just remind, and by the way, I just needed to be reminded that Ozempic is not yet approved by the FDA as a weight loss medication. Those doctors who prescribe Ozempic are prescribing it outside of FDA recommendation, something that as physicians we do all the time. There's nothing wrong with that. But Wegovy has been approved by the FDA, and they're basically the same molecule. One is twice the dosing of the other. But what I was trying to say was, if you have any anxiety staying on these medications long term, keep in mind that those of us who take blood pressure medication, we stay on them for the rest of our lives. Those who take cholesterol medications, we stay on those for the rest of our lives. So staying on one of these medications for a long period of time should not create a significant anxiety for anyone. Moving on to the next level. Um, I think we've talked about most of this. Unfortunately, not all insurance companies cover these new drugs, which means a lot of patients, the only way they can have access to them is to pay for them out of their own pocket. And unfortunately, they do tend to be expensive. And yes, what we do know is that even super successful patients, when they stop taking the medicine, some of them go on to struggle with weight regain. All right. Now we're going to start talking about interventions. Interventions for weight loss, which start out with endoscopic approach, things that we do without a surgical incision. There's no cutting. We go through the stomach, for example. Here are two examples: stomach balloons, and then endoscopic sleeve gastroplasty, which is kind of similar to what we get from sleeve gastrectomy. Let's talk about each of these separately. Gastric balloon, um, there have been several balloons that have come to US market. Today, the only one that is commercially being used is the Orbera gastric balloon. The reshaped gastric balloon is no longer available. Obalon gastric balloon is no longer offered by the company that owns it. And Spatz gastric balloon has not yet, to my knowledge, been launched in the US, even though FDA has approved it. Nevertheless, they all tend to work the same way. There is a large volume balloon the size of a grapefruit that sits inside the stomach and gives you a feeling of fullness. Imagine going to Thanksgiving dinner early in the afternoon and eating a full meal, but then 2 hours later having to go to your in laws for a second Thanksgiving celebration. Clearly, you're not going to be able to eat the same amount of food. And having a large balloon the size of a grapefruit in the stomach um, basically provides you with that constant sensation of fullness. And patients can do very well with gastric balloons. The problem, the biggest problem with gastric balloon is that it can't really stay in the stomach for a long period of time. The longer it stays, the higher the incidence of complications as a result of pressure exerted by the balloon on the lining of the stomach. So ulcers can form, bleeding can happen, heaven forbid, perforations can happen. Those are extremely rare in the first 6 months. And that is why the balloon is approved for 6 months stay in the stomach. Beyond 6 months, it's really not advisable. And as a result, you can imagine in 6 months, the average person might lose about 30 to 50 pounds, not a whole lot more than that. Patients have often asked, can I have a second balloon after the first one? And the answer is yes. So you can have a first balloon, you can have it removed at 6 months, you can lose 30 to 50 pounds. And after giving your stomach a break for about a month, you can go back and have a second balloon. The biggest problem is, unfortunately, insurance companies think of gastric balloons as a temporary measure. And as a result, they don't cover them. And therefore, not everyone can afford losing the weight that they want to lose with gastric balloons. So I generally tell patients, if you're okay with 30 to 50 pounds weight loss, and if you're okay with financing it yourself, gastric balloons are great. You should definitely consider it. If not, you may have to consider going to more traditional surgical interventions. Um, this next procedure I'm going to spend very little time on, endoscopic sleeve gastroplasty, is basically suturing the stomach to itself internally, endoscopically, so that only a portion of the stomach is available for volume of food. So this outer part of the stomach is excluded. Everything stays inside, obviously. This is an endoscopic procedure, not a surgical procedure. And this procedure tends to work a little longer than gastric balloon. So you can expect the effect of the procedure to last about 6 months to a year. You might ask, well, what happens after that? Believe it or not, the constant pressure exerted on the sutures, I have a hard time finding my mouse again, the constant pressure exerted on the sutures as a result of stomach getting filled with food eventually results in the sutures falling apart. And when the sutures fall apart, it's not a catastrophic event. Patients don't even know that that happened. All that does is makes the procedure no longer a viable functioning procedure for the individual. And most patients tell us in about 1 year, they can no longer tell that their stomach was sewn to itself. So I would say maybe about 50 to 70 pound weight loss with this procedure. Again, unfortunately, insurance companies tend not to cover this, and it becomes a financial challenge for many people who are looking for ways to lose significant amount of weight. All right, next on the hierarchy of intensiveness of intervention, lap band surgery. Many of you might have thought or might have been told by even your primary care doctor and other healthcare professionals that you come across that lap band surgery is no longer offered in this country. That's really not true. Lap band surgery is still around, and for many patients, it's a great way to lose weight. If you're wondering what happened, that in around 2010, better than 50% of all operations performed for weight loss was lap band surgery. And today, that number is down to about 10%. So instead of 50 plus percent, we're talking about 10% or maybe even less. What happened exactly? Well, the main reason the numbers dwindled is because surgeons, who I'm talking about people like myself, who are not in the business of providing long-term care to their patients, decided that they didn't enjoy the aftercare necessary for lap band. So the most successful of lap band patients have to come and see their surgeons for band adjustments. Band adjustment is what allows us to have this blood pressure cuff like device around the stomach tightened or loosened. When the band is nice and tight, and by the way, all of this is internal, nothing sticks out. This reservoir is under the skin. It gives us access with a simple needle and a syringe to make this band tighter. When the band is tight, a person eats a small volume of meal, about 2 hard-boiled eggs, maybe 3 chicken nuggets for lunch, or 3 small meatballs for dinner. And that food, instead of going straight through into the big part of the stomach, it sits here and gives a person a sensation of fullness. Then over the course of the next few hours, that food breaks down and works its way through the band. And when that happens, a person might be hungry for their next meal. So successful band patients eat a small breakfast, a small lunch, and a small dinner, and in between, they're not hungry. And that's how a person loses weight. Other great attributes, the band is adjustable, so the effect of the operation is tailored to the needs of individual patients. It's a very, very safe operation to perform on the day of surgery. It is done as outpatient surgery, and it is very easily reversed. So if a person has issues with their band, or they simply decide that they don't want to have the band in their body, it's a very simple operation to go remove the band. Now, arguably, the effect of gastric banding can be longer lasting than any other surgical procedure. The band doesn't have a brain. As long as it's inside your body, it will do exactly what it is intended to do, which is make it difficult for a person to eat large portions of food at once, as long as the band is in there. And there are patients who've had their bands for 10, 15, 20, and even more than 20 years and have been able to benefit from it for that entire length of time. Now, there are some challenges with the lap band. Number one, weight loss tends to be a little slower with lap band compared to the stapling procedures. So maybe 1 to 2 pounds a week instead of 2 to 3 or 2 to 4 pounds a week with gastric sleeve and gastric bypass. And it is very important that the patients come for their appointments um, initially, maybe monthly, to get their band tightened. Without those band adjustments, the device is essentially useless to a person. And there is such a thing as compliance fatigue. Compliance fatigue means I constantly have to coach my patients into following a certain type of eating to be successful with their band. For instance, they too are told that liquids go right through the band and they need to avoid liquid calories. And so compliance means following the rules of appropriate eating with the band and following the regimen of coming back and getting the band tightened as needed. And many patients over the years fall off the wagon and essentially get tired of following the rules. And that's when they start noticing that the band is no longer doing what it was intended to do for them. We can continue this conversation during the question and answer. I'm going to move on to the next. Gastric sleeve is the most commonly performed operation around the world in the United States, and at this point in my own practice. It's an operation where we remove about 2/3 or up to 3/4 of the stomach and leave a narrow tubing behind. Essentially, what this accomplishes is two major things. One is limited capacity for food. Again, about 2 hard-boiled eggs for breakfast, 3 chicken nuggets for lunch, 3 small meatballs for dinner. But there's a major second thing that comes from this operation, and that is this part of the stomach that is removed is responsible for creating or secreting hormones that make us look forward to eating and make us hungry. And therefore, after this large portion of the stomach is removed, those hormone levels, known as ghrelins, go down substantially. And as a result, as a result of that, patients tell us they go through the whole day without thinking about food. They don't miss it. They don't feel deprived. They're not upset that other people are eating in front of them. It's exactly the opposite of how we feel when we are dieting. And that's what makes this operation so popular and so successful. So far, it's all been very, very positive. Well, we don't have a perfect operation, and gastric sleeve, unfortunately, is not a perfect operation. The biggest shortcoming of the operation is that over time, no matter what our patients do, the body tries to heal from the impact of the operation, which means over time, this narrow stomach will try to expand and get back to its original size and shape. And in about 3 years, the stomach expands enough, stretches enough that a lot of our patients tell us they can no longer tell they've had surgery. Now, at that point, about 90% of our patients have reached their desired weight. But if they are going to keep that weight, they have to do the hard work. And hard work means eating more responsibly, and hard work means increasing their activity and exercise so that their metabolism stays up. If they do some of that, hopefully they'll be able to maintain their lost weight. If they go back to their old habits, unfortunately, a lot of patients can gain their weight back. This brings us to the last two procedures, gastric bypass and duodenal switch. I am going to talk about these two kind of in one category. And let me just sum it up by telling you that both procedures involve not only cutting the stomach, but also rerouting the small intestine. So you can see this part of the intestine used to be continuous with this part of the intestine. When we cut it, we brought it up and sewed it to this part of the stomach. And then we had to bring the intestine that delivers the bile from the liver back and sew it to the lower part. And so a good portion of the stomach and intestine is bypassed, and this contributes to a little bit of malnutrition, but also a significant amount of restriction in how much food a person can eat. So gastric bypass patients not only have restriction in how much they can eat, but also of the food that they eat, not all of it gets absorbed. And as a result, there is some element of malabsorption. That is why gastric bypass patients tend to lose the weight a little more rapidly than gastric sleeve patients. And I'm going to quickly go to the next slide, which shows the anatomic alteration for duodenal switch. Duodenal switch starts with sleeve gastrectomy. So removal of this portion of the stomach is identical to sleeve gastrectomy, but it also has a second step. The second step is this part of the intestine used to be here, and we cut this part of the intestine used to be attached to here. This was attached to the first portion of the duodenum. This is a little complicated. We cut it and reroute it. And for both of these procedures, the rerouting of the intestine comes with some advantages and some disadvantages. The advantage is there is some element of malabsorption, which contributes to faster weight loss and more impressive weight loss. Um, the disadvantage is that as a result of rerouting the intestine, there are some complications that are unique to these two procedures for the rest of the life of the patient. Internal twists, blockages, and bleeding can happen as a result of rerouting the intestines. And also for duodenal switch, the malabsorption is significant enough that patients do have to be on lifelong supplements. Now, you might think that by sharing the information about gastric bypass and duodenal switch, I might be skeptical about these two procedures. No, much to the contrary. I believe gastric bypass and duodenal switch are great operations, but maybe not as the first choice operation for people who are having their first bariatric intervention. I tend to think that, unfortunately, despite our best efforts, a lot of our patients will go on in their lifetime to have more than one intervention, especially if they start early. If a person has their first surgical intervention in their 30s, you can almost imagine that by the time they're in their 40s and their 50s, the effect of the operation has worn off and they might need to have another operation. And at that point, going from, let's say, lap band surgery or gastric sleeve surgery to gastric bypass or to duodenal switch would be a perfectly appropriate operation.